Hello, everyone. My name is Stacy Rothwell, and I am a Field Services Program Manager with the Oregon Office of Rural Health, and I would like to welcome you to the 37th Annual Oregon Rural Health Conference. I will be your moderator for this session. First, I'd like to thank our great sponsors. Because of their support during these challenging times, they've made it possible for us to offer this conference to you at no cost, and we are very grateful to them for that. So please join me in thanking our gold sponsors, the Oregon Rural Health Association, All Care Health, our silver sponsors, Eastern Oregon Coordinated Care Organization, the Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes. Our bronze sponsor is RQI Partners, and our copper sponsors are Westcom, the American College of Education, and InquaSpeak. You should have received an email regarding the link for our conference app. You can use the app to visit our partners' virtual booths. You can enter to win prizes, network with others, and we invite you to share photos of your hometown. Next slide. Don't forget to complete the evaluation survey about this session. This is how you get your continuing education credit. Even if you're not seeking continuing education credit, please complete the survey anyways, and it will enter you into a chance to win a $100 gift card. Keep in mind we do review all of the evaluations, and your input is important to us. This session, can a comprehensive medication management program be financially sustainable, will be presented by our friends at Santiam Hospital. Dr. Tony Hotan with Santiam Hospital and the Aumsville Medical Clinic, Maggie Hudson, the CFO and COO of Santiam Hospital, and Dr. Tiffany Pye, the Director of Pharmacy at Santiam Hospital. Without further ado, I will hand the presentation over to you.
Thank you, Stacy. I'm Maggie Hudson with Santiam Hospital. First of all, thank you for inviting us to share our journey on the Comprehensive Medication Management Program. Although this topic is, we're in 2020 right now, and this journey began back in 2016, there's still very relevant components of this journey that we would like to share with you today. The conversation around whether it's financially viable is really related to its ability to be financially viable in a direct billing methodology. So as we go through this conversation, keep in mind that we were looking at being able to afford a clinical pharmacist embedded in our clinics so that we could actually sustain their salaries. We didn't expect them to sustain their extra overhead or other costs, but just the salary component. And that was really where we started in terms of financial stability. So a comprehensive medication management program, as all of you know, is the collaboration of a clinic-based pharmacist working in conjunction with the providers to individually assess each patient's medications needs. And as we know, in this era of family medicine, it's very difficult to manage all of the medications. So bringing in a pharmacist is really the goal we've all had, and moving this program forward was very, very important to us. So that starts where we were back in 2016. Now we're in 2020. This is really how life feels now to us, and I imagine that's how it feels for all of you. So I know we're not thinking about medication management. We're thinking about COVID-19. And us, we are thinking on Tuesday, September 8th, around 11 a.m. is when this photo was taken. This is about 2 months ago. And as you can see, there are very dark skies for us. These skies represented the fact that we had, by this time, transferred all of our patients out. We were on evacuation level 2, thinking that the fire was going to be headed our way into Staten and that we would be evacuating all of our facility. Luckily, the winds changed and things rerouted, and we're happy to report that we did not have to evacuate, although we did not accept inpatients, and most of our services were closed for a few days. So bringing us back to where we are, this is Santiam Hospital. We are a 40-bed acute care hospital. We are not a critical access hospital. We are independent. We have a series of clinics. So we're a 40-bed acute care hospital. For the state purposes, we are a type B rural hospital. For Medicare purposes, we are a DRG or OPPS hospital. And so it's kind of an interesting mix because we don't really enjoy all of the benefits of being a rural hospital, and yet we're not large enough as far as like a DRG type of a hospital. So I always call us this awkward size. I do say that fondly, but I just feel like we kind of hit a niche, but for most intents and purposes, we consider ourselves rural. We're 15 miles from Salem. We have Silverton Hospital 15 miles north of us, Lebanon Hospital 15 miles to our south. And so we are surrounded in a very competitive yet collegial environment with the other local hospitals. When I say we're a hospital, we're also what we consider to be somewhat of a health system. We've evolved into that. So we own and operate 12 clinics. 6 of those clinics are primary care clinics, and they actually happen to be rural health clinics. I imagine most of you in the audience have rural health clinic status as well. And that's an important distinction when we have this conversation around comprehensive medication management, because you could just say, well, the pharmacist is embedded in the cost of the rural health clinic status, therefore it is covered. And by and large, that's very true, and that is the way to look at it. But when we're looking at it on this basis of direct billing and whether or not it's sustainable in and of itself, that's the different conversation. So we are very mindful that it could be part of our cost as it relates to a rural health clinic status. And that's just a different conversation. So as we embark on this program, we've evolved from a hospital and opened in 1952 to more of a small system. So we have the main hospital campus. The building that you're looking at was actually built in 2003. That's a replacement hospital. So it basically has a surgery center, a birthing center, medical surgical beds, and a 4-bed ICU. And then we have on our campus, most of our clinics, all of our other direct patient care services, our administrative services, and we have 3 satellite clinics. So we'd like to start with those clinics because those are where the pilot projects really began. So one of our clinics is located in Mill City. This is our clinic. Going back to the wildfires, we actually thought for about a day we had lost this to the fire, but our clinic did survive in Mill City, we're happy to report. This clinic is 15 miles to our east in the small town of Mill City. The Mill City's population is about 2,000 residents, and the surrounding areas between Lyons and Mahama up to Detroit, Indiana, that covers about 4,000 residents. So that's about the scope and size of this particular clinic. The other clinic involved in the project is our Aumsville Medical Clinic. This is the first clinic that Santiam Hospital opened in 2001. The Aumsville Medical Clinic is obviously located in the town of Aumsville, halfway between Staten and Salem. The population of Aumsville is about 4,200 residents, and these practitioners, of which Dr. Hotan is one, have actually been in that clinic since 2001. And so we're happy to report nothing happened in the wildfires with this clinic. And then we have a third medical clinic that is a satellite, and that is in the town of Sublimity. So talking about the pilot program, basically, we thought the easiest way would be to go through a timeline. Basically, in 2015, pharmacists are recognized as providers in Oregon. Just because they're recognized, I'm sure all of you are very well aware, it didn't mean instantaneous credentialing. And so we've been going through this process over these past few years as to how to properly credential a pharmacist as a provider. But that happens, and simultaneously, Dr. Hotan is going to talk about her inspiration to this program. But in March of 2019, we as an organization, Santiam Hospital, invite all of the local pharmacies to a community stakeholder meeting, as well as other community members, and invite them to have a conversation around polypharmacy. We found that our local pharmacies really understand a great deal about what happens in the medical clinics of all of our clinics, and they couldn't wait to have an opportunity to be at the table and participate in this conversation. We decide that we need a grant in order to pursue this pilot. So we apply for a grant through the local CCO at that time, Willamette Valley Community Health. We were awarded a grant of about $228,000 for the duration of 18 months. So this project is the duration of 18 months of work so that we had support from our local CCO, which we really valued. We decide to work with the local pharmacy, and many of you in your communities likely have smaller pharmacies, locally owned pharmacies, as we do. So we partnered with the Sublimity Pharmacy. They have a couple pharmacies in town. They are great partners, and so we begin this project. And as the time goes on, we learn many other things, and we develop into a relationship and a partnership with Pacific University, and we get then to even a national level through the A3 Collaborative. So what I would say in this regard is what it really takes is the initiative of a physician or provider champion. And so I would like to introduce Dr. Tanie Hotan. She is a family practice physician who practices at the Aumsville Medical Clinic. She is pictured here in this photo. And the importance of somebody like me in my position, having physicians or providers coming in and discussing their excitement level of a project. You really need that physician champion or provider champion coupled with the desire to move a project forward. And so pictured here, you see Dr. Amy Sutkiss, who championed the project in the clinic in Mill City, of which you saw a picture, Dr. Hotan, pictured, as well as Dr. Tiffany Pye and Melissa Netlin, who is the owner of the Sublimity Pharmacy. So at this time, I'd like to introduce Dr. Tony Hotan. Thank you.
Good afternoon, everyone. Thank you so much, Maggie, for that warm introduction. My name is Dr. Tony Hotan. I'm a family physician at Santiam Hospital. Super excited to be here, speaking to you, to my rural friends, because you are part of my tribe, and this is really exciting what we're doing at Santiam Hospital. I want to share with you what the role of being a clinical champion, a physician champion, this is something that speaks very loudly to me, because I feel that as a physician champion, you just need to be a diplomat. And that means creating opportunities when you see them, and rounding up a troop of colleagues that are like-minded and are just as passionate about what you believe in. So what happened to me was I attended a great conference in February of 2016 up at OHSU. At that conference, I heard Dr. Howard Hayward, internist from Kaiser Permanente, speak about a disease state called polypharmacy. And so polypharmacy is when you have a patient who is on 5 or more medications. That's the definition. I'll tell you what happens when you're on 5 medications, there's a very good likelihood that this medication will interact with this one and vice versa. There's also a really good chance that there'll be side effects from medications. And so what can happen with polypharmacy is that the medication management plan is not optimized. There's no one really orchestrating how everything is working in synchrony. And so Kaiser Permanente published some great data regarding outcomes when a population has a large percentage of polypharmacy. Embedding a clinical pharmacist into the workflow of the clinic can significantly reduce negative outcomes, can significantly reduce adverse effects. And so what you will have is that the idea is you will have less falls, improved functional state, you will have decreased hospitalizations, decreased ER visits, because someone's really working on optimizing the medication plan. And that was my excitement for that day. And so I ran to my colleague, Amy Sutkiss, who was also attending the conference. And I said, we are getting ourselves a clinical pharmacist. And we did. So next slide. All right. So here was the exciting part. We have the state of polypharmacy, and we were trying to deprescribe to improve functional scores. We looked at our prevalence rate of polypharmacy, and it was 49% within my patient population of Aumsville, and in Dr. Sutkiss's population in Mill City. We also surveyed our internist colleagues, and their population had about 80% polypharmacy. So we knew the prevalence rate was high. And then the hope of change, the hope of improvement was significant. So we launched a program after being awarded the grant for 18 months. And then we quickly found out that in order to see outcomes, we needed to pick metrics that were easily identifiable. So we adapted from looking at polypharmacy and deprescribing to looking at systolic hypertension, as well as hemoglobin A1Cs over time. It was a realization that we needed to capture these metrics that were easily identifiable and automatically reportable from our EHR. So then Dr. Pai is going to be sharing with you some of that exciting data. And so let me go to the next slide. So this is a busy slide, but the take of this is that this is the infrastructure of our program. On my left-hand side, the orange column was the problem or the rationale, the challenge. That challenge was the unoptimized medication plan. It was also a challenge because at that time in 2016, we had the opioid epidemic. And then we also had a culture, and we still do, we have a culture of prescribing for pretty much any symptom that the patient is presenting from. And so we took that, and the green arrows you'll see are the strategies, again, implementing, embedding clinical pharmacists in 2 rural clinics over 18 months. On the more right-hand side, you'll see short-term goals. That came easily with improved medication accuracy on the med list. That's huge. And I think any provider who's out there in the audience will say, oh my goodness, thank goodness we have improved medication list. And then it also worked towards the right-hand side, which is the green side. Can we actually change the culture in our system so that if you have a diabetic patient, will she be welcomed at the clinic and have a team-based approach where she'll see not only myself, the family physician, but she'll see our behaviorist, and then she'll see our pharmacist. Because I know that when I am functioning in a team-based approach, my outcomes are going to be better. I'm going to have reduced hemoglobin A1Cs, targeted hemoglobin A1Cs. My hypertension population rate is going to be improved because of the team-based approach. So again, just to rephrase, the role of the physician clinical champion, because I've been practicing at the Aumsville Clinic and the Santiam community for 19 years, I feel that I have the leadership and the understanding of our culture, and I was able to set a setting where I could support our clinical pharmacists, really encourage her presence and facilitate her presence. And that's very important for the first few months of the program. Once her effectiveness was noticed, then she will generate her own patient flow. But that's very important to have a clinical champion paving the way to support our pharmacists. The other component that is just as important is the financial stability of the program. And so Dr. Pai is going to speak about that right now. Thank you.
Hi, I'm Tiffany Pai. I am a pharmacist and the current director of pharmacy at Santiam Hospital. When we started this program, as Dr. Hotan mentioned, there is a lot of evidence that clinical services provided by a pharmacist can be financially justified by soft dollars, such as increased patient outcomes, increased metrics. But we wanted to look at other pieces of it. Can it be financially sustainable through direct billing? We knew that there was a barrier for direct reimbursement because of the differences in state and federal laws. On a state level, with the passage of House Bill 2028 in 2015, Oregon recognizes pharmacists as providers and permits insurers to reimburse for clinical services. And I say permits because it's not mandatory. It's a may, not a shall. And this became important as we worked through the credentialing process. And to date, CMS and Medicare do not recognize pharmacists as providers. As we started our project, we started with the premise of a pharmacist as a mid-level practitioner. we worked with our credentialing department to navigate insurance credentialing and contracting, and worked to credential the pharmacists with each of our main third-party payers. We wanted to know what percentage of visits were completed per insurance type, what the median reimbursement rate was, or the dollars per visit, and the estimated number of visits we would need the pharmacist to perform per day to cover 100% of the total CMM cost. And as mentioned by Maggie earlier, the total cost that we were looking at was the salary of the pharmacist, and we did not include the incidental costs of adding a teammate to a clinic. So after 18 months and over 700 visits, we found that there were 81% of our visits were government sponsored, with about 60% Medicare and 21% Medicaid. Of the payer mix, 34% were Medicare Advantage and 25% were traditional Medicare or Part B. We had about the 21% Medicaid, 18% commercial, and about 1% self-pay and TRICARE. This was important in the median reimbursement rate as well, which we found to be about $36 per visit, with a range of anywhere from $10 to $76. And we found that in order to cover 100% of the pharmacist's costs, we would need to have 17 visits per day, which in an 8-hour day is about 28-minute appointments on average. This can be somewhat difficult as the pharmacist appointments tend to be a little bit longer than a half hour, especially the initial visits. So this is a really exciting and interesting slide with each of the insurers. So as we went through, we found that we had 14 main third-party payers, and we worked through credentialing and requesting reimbursement and contracting for each of these. Of the 14, 9 credentialed the pharmacists and provided reimbursement. 1, listed on here, MODA, did not credential the pharmacist, but did provide reimbursement, which we found interesting. And Providence would only credential the pharmacist under certain circumstances, such as board certification or residency training. But then on the contracting piece, we found that the rate that they were willing to reimburse was not agreeable, and so we did not credential nor contract with Providence. And then 3 major insurers that did not credential for the pharmacist were the Medicare Part B, TRICARE, and Cigna. This was it was a success to see 11 of the 14 third-party payers willing to credential and reimburse, which was uncommon in 2016, 2017, as pharmacists were getting started as providers in Oregon. With this, we determined that you couldn't just depend on direct reimbursement to financially sustain a CMM program. It was also very important to show the patient outcomes and to look at both the increase in quality metrics, patient outcomes, and direct reimbursement as pieces of the puzzle. We were able to do some preliminary analysis of our clinical outcomes, and here we had 103 unique patients in the 18-month pilot program that had a diabetic diagnosis, had an A1C checked before intervention with a pharmacist and then after. And we found that there was a change from 8.8 of an A1C to 7.8, which was statistically significant. For hypertension, we also had 29 unique patients, which isn't a huge number, but we were able to show a statistically significant decrease in their systolic blood pressure from 158 to 132. We felt that with the strong physician champion and an excited pharmacist willing to do the work, we had a successful program. And we also realized we needed a lot of partnerships. We had to have senior leadership support. We had patient accounts and credentialing support, and there was still more. So we found a lot of value in building partnerships beyond just the hospital and the clinics. WVCH, our CCO at the time, became a great partner with the grant, allowing us to pilot this program. Sublimity Pharmacy Services provided 2 pharmacists to help pilot this program, and a knowledge base of the local community. From there, we built on with Pacific University to bring on a fellow and interns into our program. And then on a national level, we built a partnership with the A3 Collaborative, who the A3 stands for ASHP, the American Society of Health System Pharmacists, APEXIS, which many of you may be familiar with on the 340B side as the HRSA's prime vendor, and then AIM, which is the Alliance for Integrated Medication Management. And this collaborative is really a CMM coach to help work through the different processes of your program, have group discussions with other CMM programs, provide performance stories and feedback to be able to continue to grow the program. We were able to publish our results of our pilot program, which we were so excited about. The article was published in January 2020 in the Journal of Managed Care and Specialty Pharmacy. It's a really exciting read. If any of you want to look it up, it's available online. But we learned so much from this process. Ultimately, I think we showed the value of the multidisciplinary approach, the community involvement needed to tackle the status quo. And organizationally, we learned how to better utilize our pharmacy department, not only with our partnerships with our local pharmacy, but within our program. And while some of our processes have changed since 2016, we have been able to continue to grow clinically in the pharmacy department, as well as show to work together in a multidisciplinary way. Okay, and here are our references. Any questions? I don't understand. Should I?
Stacey, are you there?
Okay, can you hear me?
Yes.
Okay, so I went through the whole thank you and was paused. So, or I was on mute. Sorry. I'm going to turn my camera on. Okay. Thank you, Dr. Hotan, Dr. Pai, and Maggie for sharing your journey with the CCM. Thank you, Dr. Hotan, Dr. Pai, and Maggie for sharing your journey with CCM with us today. You've accomplished so much in such a relatively short period of time, and I am certain that your story will be beneficial to others across Oregon who are considering CCM in their clinics. So we will now go to the question and answer session.
Hello, everyone, and welcome to the live question and answer portion of this session. I just want to give a second for our presenters to get into the live session. Okay, looks like we're all here. Okay, I'm going to start with our first question. Just a reminder for everyone, if you have any questions for the presenters, you can enter those into the question and answer box down on the bottom right-hand corner of your screen. But I'll get started with our first question for the presenters. If other institutions were interested in implementing a similar CMM program, how would one assess the institution's readiness to adopt such a program and be successful? And then a second part of that question is, what would be the signs that the institution is not ready? Tanie, I think that you might be muted.
Me now?
There you go.
Okay, sorry about that. Hi, thank you so much for your question, Stacy. So thinking about your organization's readiness, you can think about all the current committees that you're already on and how they flow and how motivated each individual is. And so when you think about taking this is a huge project, it's a huge undertaking. You want to make sure that your core group is solid and is very motivated, continuously motivated, and ready to take on a lot of no's from people, because what's going to happen is you're going to be presented with a lot of barriers, and you need to work through that. So it's more about the composition of your core group and how motivated and supportive each person is. And if you don't have that really strong, motivated core group, you may not be ready for this kind of challenge. Because if you look at the literature, most CMM programs do not continue long term. Only about 5 to 10% of them do. And so knowing that, you have to read the literature, what works, and it's really about your core group and the champions and the supportive team within your core group.
Perfect, thank you. We do have a question in the chat box from Ashley. How did you get patients on board to see the clinical pharmacist? And also, how often did you require patients to see the clinical pharmacist?
I can answer part of that. So we had multiple ways of entering into the CMM program. You could be a self-referral. We had signage. So first of all, let me just back up. There needs to be a marketing component to this. So we had videos, we had signage. We instructed our receptionists to let the patients know that a pharmacist was present. Our medical assistants could also, speak highly of them. So it was really a team-based approach. The patient could get an appointment with a pharmacist, but most of the times, what it would be I would say, hey, Mrs. Jones, your hemoglobin A1C is elevated. Let me introduce you to Tiffany. So I would do a warm handoff. She's right in my clinic. And say, let me just introduce you to Tiffany. And so once you meet Tiffany, she's so adorable and so likable that you're going to want to follow up. So it's usually a warm handoff that generates another visit, probably at another time.
Perfect. Thank you.
To answer the second part, we didn't require the patients to see a provider on. We tried to do like a 3-month follow-up, but it was really patient dependent. If the patient was coming in to talk about their A1C and we were adjusting diabetic medications, then we would wait the 3 months. But sometimes it was a monthly visit when we were working on deprescribing and really trying to help optimize their medication list. And so I think it was much more patient dependent, but we did try to follow up on the 3 and 6 month cycle.
Perfect, thank you. Next question, how much of the overall cost was covered by direct medical billing?
So out of the 700 visits that we had in that 18-month period and what we were actually able to get paid and went into the bank ended up covering about 14% of the overall cost. So the grant became very important to be able to support the pilot.
Another question that we have is, are you able to utilize Dr. Pai within the hospital setting as well as in the clinic setting? What percentage of her FTE or your FTE was dedicated to the clinic versus the hospital?
Are you tackling that, Tiffany? I would say so. Tiffany was actually part of the sublimity pharmacy when she came on the project. So she was not an FTE of the hospital whatsoever. So her role now as the director of pharmacy is in-house. So she was not an in-house pharmacist. We had a full-time pharmacist position that we were able to afford as part of this grant. So she was a full-time FTE in the clinics, not at all in the hospital at that time. We obviously hired her as a result of it, right? It was such a successful project. We decided she had to come in-house.
Excellent.
Yeah.
Another question that's come in over the chat from Edward. How have you been able to attribute improvements in quality metrics to the pharmacist intervention rather than to the team as a whole? So were you able to separate out the two, or have you been?
So I would say it's a pharmacist-led program, but it is really, you want to think of this, I think of this as the team, because as protocols and as Tiffany educated us about various medications, we implemented it outside of the pharmacist visit. So it's definitely, I think, more of a team-based approach. It's the ripple effect. She's the center. She starts it. She's the catalyst. She reinforces great management, evidence-based medicine, and then we work off of each other to spread that across the clinic. So I don't know how you would separate that.
Okay, and a follow-up question from Edward as well. Did patients with commercial insurance have visit copays when they saw the pharmacist, and was that a barrier for you?
Copays were definitely a barrier all the way around in every element. And so because we had grant funding, we typically did not charge a copay. And I do feel if patients had to pay a copay, there would be more reluctance to see the pharmacist too. So it was trying to educate the patients about this is really a specialist. And the copay is very minimal, but we did have barriers with copays, yes.
So just to give you some numbers, I think the specialist copays were maybe $30 or $40 per visit versus seeing a primary care provider. It was usually less, maybe $10 to $25. And so that made it very challenging. So yes, that was a problem.
Okay. And then what advice would you have for other rural clinics or hospitals that are wanting to start a CMM program, and what resources are out there that you would recommend for them?
Go ahead, Tiffany. You look like you were going to say something.
Go ahead.
Well, I think there's so many different pieces of it, but I think having a strong physician champion definitely helped us get things going. But then pursuing your outside resources like a grant and utilizing the A3 collaborative has helped. Like hindsight's 2020, and looking back, it would have been great to have that information and that infrastructure because we often felt like we were. It all felt so new, and that we were so groundbreaking. But I think looking back on it, we probably had more resources out there that we didn't realize that we could take advantage of. So I would definitely look for a collaborative and grant funding to start a pilot project like this.
Mm-hmm. And honestly, I think if I recall correctly, here's what we did. We held a lunch. So we held a lunch. I walked to every local pharmacist around and I said, here's a flyer, come to my lunch. We're going to talk about polypharmacy. I recruited Dr. Hayward to come and be the guest speaker. And then it was a house full of retail pharmacists, myself, Dr. Hayward. And then after the meeting, we said, look, we're going to start a little committee or something. Or I think some of the pharmacists just jumped on me and said, we're doing this with you. And so I didn't have a choice. And so basically, if you hold a lunch and you feed them and then we have a conversation, that's what it was. And then it's a conversation, because I only have one piece of the puzzle. Tiffany has the other piece, and Maggie had the financial piece. And then looking at literature, because we have precedents in the Midwest. They have been doing CMM for 10 years prior to us. And the beauty is that we can look at models that are similar to ours that have been successful. So that's kind of what we did, and it seemed to work.
Yeah, bringing those, the pharmacist and other community partners together is a great idea. You can always get people there with food. That's probably number one, bringing the meetings together. But that's great. And also having that data from other states that have done that, to be able to show them that it can be successful, and it's an important piece. I had one other question for you, and it was whether or not, is it too early to tell, or are you able to separate out? It's kind of similar to Edward's question, but as far as the outcomes from the hospital side, are you seeing less patients in the ER because of this service? You had mentioned, I think, Dr. Hotan, in your presentation, that was something, a potential benefit is decreased numbers of patients in the ER. And have you been able to see that yet, or is it just too soon?
It was something that's very difficult to track. I don't think we had the data to show the decrease in ER visits at this point.
Yeah, I would agree that there's nothing definitive that has shown that.
It'd be great to see over time if you start seeing those numbers, because they definitely seem to correlate. So, okay, well, I am not seeing any additional questions coming through on the chat box. So I think that we'll probably conclude the session just a little bit early. I want to thank you guys all for doing the presentation. It's a great topic and such useful information for others who are wanting to explore this. At 11 o'clock, please join us for our next session with the Samaritan North Lincoln Hospital team. Their session is titled Innovation in an Oregon Critical Access Hospital. So we'll give everybody a little bit of a break and come back at 11 o'clock. And again, thank you, and thank you for everyone for attending this session.
Thank you so much.
Take care.